episiotomy in like general terms is basically if you are pushing a baby out and there is not enough room for whatever reason, the indications for doing an episiotomy vary, and we can go over some of those. You would usually use curved Mayo scissors or episiotomy scissors to make an incision. The way that this essentially looks is if you imagine like, let's see, typically this is done when the baby's fairly close to delivering. So if you pretend this is the baby's head and we get a different color for okay, baby's head's going to be blue. Okay, baby's head's right there, kind of crowning. So you would have like the vulva looking like this. The urethra is here, usually fairly compressed. Clitoris, clitoral hood here, typically fairly stretched here, and then rectum there, anus there. Does that make sense? So blue is the baby's head, crowning, and an episiotomy would be where you would take your instrument and you either make an incision here to allow for more space for the head to exit, or for a beautiful picture, sure. More space for head to exit, or to put an instrument in like forceps or something like that. Or that one's called a medial episiotomy, and then you can also have medial lateral going to the side. And generally when you do that, you're going to, let's see, I would put my fingers like this between, gosh, I don't know how to demonstrate this. So if the head is, okay, baby's head is coming out this way. Pretend that's a whole circle. I don't have a circle. Here, look, we'll use my bracelet. Can't see any of this. It's inside. Okay. This would be a medial episiotomy. See how there's a disruption now of the vaginal wall? And to cut it, I would put my fingers here between the perineum and the baby's head, like that, and then use the scissors to cut this way so that you don't cut the baby. Does that make sense? So let's see. Lots of people discuss pooping in birth. Is it possible to pee during birth? Yes, sometimes that happens as well. Would you do an episiotomy for a faster delivery in an emergency? Sometimes, yes, that would be something that could be a reason to do that. Is it better than natural tearing? No, we used to think, not we, but like older generations used to think that it was more beneficial to do an episiotomy rather than tear, because it's a clean cut and then easier to repair and heal. But really we've found that that's not the case. So episiotomy to prevent tearing or for better healing is not really an indication anymore. And then so someone said, I have a friend who said they cut an episiotomy so that they didn't tear it towards the clitoris. This is a hard thing to study, right? But I have absolutely 100% been in deliveries where I was like, if this happens, because sometimes you can kind of just see it coming, like this is going to be really bad, and so there probably isn't data to support that, but personally I would say on an individual one-to-one basis, and I can probably count on one hand the number of episiotomies I cut per year, but there are situations where I'm like, I really think if we don't do this, that you might end up with a tear that's worse if we don't, and it's totally up to you, and I could be wrong, but so yes, there are reasons why that's the case. Why upwards and not downwards? So you wouldn't want to cut upwards because right here, that's the urethra. So where your pee comes out, and that's the clitoris. So you'd be immediately into something that you don't want to cut the bladder, if you went past the baby's head to the inside and like right here, so this is inside the vagina, right? So if you went around the top of the baby's head into the vagina and then like pressed up, that's the bladder. So you could easily cut into the bladder, urethra, and clitoris in one small cut if you did that. Forceps can be dangerous. I explain forceps like a scalpel. Scalpel could be a weapon, but it also can be an incredibly important tool for taking care of people. So forceps are the same. If you know what you're doing and you do it safely and you're well trained to use them, then forceps can be a life-saving tool. Yes, it is not uncommon to hear about doctors doing episiotomies without saying, explaining, or asking, and I think that is not okay. Thank you, Savory Carolyn. Happy to have you here. Why not on the side? Seems like, yeah, so you can't go this way on an episiotomy. Like you couldn't really make a cut here because there's really not anywhere to go. Like you're going to be cutting through the labia. It's just not going to give you the room. You have bony structures closer there. It's not going to do the job that an episiotomy is meant to do. Yeah, so someone said medial lateral versus medial, and is it because you might have that tear into what we call a 3rd or 4th degree tear where it goes through the rectum or anal opening or the sphincter muscle? It is debatable which is superior and if it is more likely or not to do that. And we'll go to our favorite resource here to take a look. Medial lateral versus midline. So World Health Organization recommends medial lateral as it won't increase the risk of an anal sphincter injury. That's also what the Royal College advises. And ACOG apparently says that it may be preferable. Median is at higher risk of sphincter injury, but medial lateral is associated with increased blood loss. In addition, it might result in more painful healing, but the data is conflicting. Yeah, so when I was training, they were still kind of in a like, oh, we don't really know what to recommend for medial lateral versus median. But current thought is medial lateral. And hang on a second, how do I get this back to where I wanted it? But I would say this is a pendulum that swings and people go back and forth between what they think is better. I thought you needed consent from all conscious patients before doing a procedure that, yeah, I mean, you do. Sometimes it's included in like the paperwork on admission and people, I don't know, but yeah, I wasn't explicitly, honestly, taught to ask for express consent for that. I definitely do. I feel like there is always time, even in a pants on fire emergency, to ask, but I don't know if you can get up to date without being in the medical field, but it is aimed at people who understand studies and things like that, like who've been trained in statistics and studies and reading scientific literature. And I think it's really expensive if you pay for it outright. Like I have access to it through institutions. It is absolutely crazy how much autonomy is removed from people who are having a baby, and it is alarming in the United States, in my opinion. I don't know how many times I've ever cut an episiotomy, but several. Most of my patients would already have an epidural, or I would put numbing medicine first. I don't think I've ever cut an episiotomy in someone who was not anesthetized, unless I can maybe remember one time where there was a true pants on fire emergency. Someone came in like preterm, baby was stuck. I couldn't do anything. And I said to them, like, I don't have anesthetic right here. I can send someone to get some. They're going to get some. or we can cut an episiotomy and try to get baby out right now. And I don't even remember what they said, but I would never do that ever without talking to someone about it. And I certainly wouldn't do it without anesthetic, without talking to them about it. Yeah, it's crazy that I wasn't told to ask. Become a doctor so I can have up to date. Perfect financial plan. Yeah. The 6 figures you spend getting your degree would pay for your subscription for a while. Yeah, absolutely. It's not just that. I agree. It's definitely not just that. And it is inexcusable. It's crazy. And it's worse in the United States. Nixie Pixie. I've seen this talked about a lot, and I am certain that this happens where people are doing exams on unconscious patients who don't know. But I do think that oftentimes when I read about it in the media, it's presented as though it's like a patient goes in for wisdom tooth removal and they're asleep, and then people are doing pelvic exams. And that wasn't my experience at all. And I don't think I went to a place for training or schooling that was particularly good about like making sure that we were respecting autonomy. My experience with learning pelvic exams and teaching them to medical students was that the only time a pelvic exam was ever done on a patient who was unconscious was when we were already planning, like the last step before I do most gynecologic surgeries is to do an exam under anesthesia once someone's asleep. If somebody's having a hysterectomy or a DNC or something like that, I usually need to feel of the position of their uterus and all of their important parts before I start putting instruments in there. And that would be, if there was a medical student with me, I would teach them when I was doing my exam already. Sometimes I feel like in the news, it's presented as though we're lining up medical students in the hallway and everybody's going to do a pelvic exam. And while I don't know if that's happened other places, I've never seen that. And, you know, I'm pretty upfront with you guys. I just told you that I was never taught to like expressly discuss certain aspects of obstetric care before I did them. And I would tell you if I had ever seen something like that, but that's not at all what it was. Here in Aotearoa, I really like that we have it expressly on our consent form. So when I'm consenting a patient for surgery, there's actually a section on the consent form that says sensitive exams. And if I'm doing a laparoscopy and we won't be doing a pelvic exam, then we just click check not applicable. But if we are doing a hysterectomy, I'll say, you know, the last step before I do your surgery is for me to do a exam to feel of the uterus and identify where things are. This can be really helpful for teaching, you know, our students how to do this so that they can take better care of people when they have, you know, they're working in the emergency room and a patient comes in who we need to do an exam like that. Would it be okay with you if while I am doing my exam, I also teach them and let them learn from you? And I would clarify, we're not going to be lining up every medical student outside. This would only be if you've already given permission for a student to be with me that day of surgery, and it would be the student working with me that day. Yeah, for sure. I mean, it should be a consent form question. It's more helpful cat under anesthesia because one, the patient is not uncomfortable, they're not hurting, and I can do a pretty pain-free speculum exam or pelvic exam for 90% of my patients, but when you're learning, that's not the case. And then the other reason is because the medical students are nervous. It is really nerve-wracking to learn to do those exams. You don't want to hurt people. It's sensitive. Most patients don't really like it. But 100%, this is something that should be done with consent. I just want to clarify, and I think I'm all in favor of making sure that that's expressly put on consent forms, but I just want to make sure that my personal experience with this is out there, which was that we would teach that when a patient was already having that exam and had given permission for students to be there and learning from them. And it wasn't lining up a bunch of people to come in and do a speculum or pelvic exam on somebody who was having an unrelated surgery. Even if it was a GYN surgery and we weren't going to do a pelvic exam, we wouldn't do it. I don't know that it would always work like that at every hospital, but that was my experience. Have you ever had a patient want to see what's going on? For birth, for sure, having a mirror actually is associated with patients pushing better because they can see what's effective, especially if they have an anesthetic on board. I've never had anybody ask to do that for like a pelvic exam with a speculum, but if they wanted to see, I'd be more than happy. Actually, At Your Cervix is a production that's coming out soon, and I think it might talk about exactly what we're talking about right now. Yeah. Documentary about consent. And they've reached out to me to ask to help promote it. I'm not promoting it for them, like they're not paying me or anything. But they asked me to talk about it, and I'm waiting on them to get back to me of what they want me to do. But they sent me this, and I love it so much. They sent me this lunchbox. Well, I wanted to show you pictures, I guess I could go get it, but it's this lunchbox here, and it says, "With my speculum, I am strong, I can fight." And it has a speculum inside it, and teaches you how to do a speculum exam and look at your own cervix, which I thought was very interesting. So anyway, I'll be talking about that at some point again as well. All right, did we learn everything we needed to about episiotomy? I'm looking here at median versus medial lateral, and I was thinking, I was taught to do median, and it says median is typically performed more commonly in the United States. And the data is a bit mixed, but I think in just reading this, and I do both in practice, I kind of assess the patient individually and try to choose what I think would be best for them. But in reading this, it sounds like it's questionable if there's real strong evidence one way or the other, but if there was convincing evidence, it would be towards a median midline. Not a subject most Twitch streams would cover. Yeah, well, probably not a subject most Twitch streams in general would cover. Once I had a fellow and resident doing my sedation. My cousin was a resident, so my sedated ass told the resident. I was so proud of her. That's adorable. You're on the second channel. Make sure you subscribe. If you're subscribed to my main channel, you might not be subscribed to MJJ Clips, so make sure you're subscribed down below so you don't miss out on any of the fun.